My name is Salvatore Carbone, and I'm a research instructor of medicine for the Polyart Center here in the Division of Cardiology at the Virginia Commonwealth University in Richmond. And I'm very excited to be here today and present the article that will be appearing in the upcoming issue of the Mayo Clinic Proceedings entitled Glucose-Lowering Therapies for Cardiovascular Risk Reduction in Patients with Type 2 Diabetes mellitus. That I wrote together with my colleagues and friends, Dr. Leo Buckley, who's a pharmacist from the Brigham and Women's in Boston, Dr. Dave Dixon, who's also a pharmacist and associate professor here for the School of Pharmacy at VCU, and Dr. Antonio Abate, who's a cardiologist, is the Roberts Professor of Cardiology and associate chair for research for the Department of Internal Medicine here at VCU. Therapeutics for patients with type 2 diabetes should be selected not only based on their effect on glycemic control, so the ability to improve glycemia, but also based on the effect of these medications on cardiovascular events. And in this review article, we really discussed the evidence of the last 60 years related to the effect of glucose-lowering agents in patients with type 2 diabetes, and not only the effect of these agents on glucose, so their ability to improve glycemia, which is the reason for which they have been approved by the U.S. Food and Drug Administration. But specifically, we discussed their role in affecting cardiovascular outcomes and cardiovascular risk factors. Therapeutics for diabetes would be approved only based on their ability to improve glycemic control. In reality now, all medications require to undergo a cardiovascular outcome trial to show at least that they're safe from a cardiovascular standpoint. And we believe that some of the medications, specifically sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists, should be preferred, particularly in patients with established cardiovascular disease, but also in those without established cardiovascular disease that present cardiovascular risk factors which could be significantly affected by this medication, specifically hypertension, for instance, in patients with type 2 diabetes, that we suggest that SGLT2 inhibitors should represent the drug of choice in patients without cardiovascular disease and after failure with lifestyle intervention and metformin, and obesity, in which in that case, we suggest the use of GLP-1 receptor agonists because of their favorable effects on metabolisms and on weight loss. Patients with established cardiovascular disease, I believe we should take into consideration what kind of cardiovascular disease patients have. And specifically, when patients, for instance, have heart failure, the SGLT2 inhibitors perhaps are the most appropriate therapeutics based on the beneficial effects resulting from the EMPA-REG outcome trial and the CANVAS program with empagliflozin and canagliflozin respectively. And in patients without heart failure, then perhaps GLP-1 receptor agonists could be even as good as SGLT2 inhibitors, or even preferred, if you will. One of the things that we also discuss in this article is the importance of assessing not only the effect on glycemic control, but also the effect of medications on the risk of hypoglycemia. We know very well that hypoglycemia is a major determinant of cardiovascular outcomes. It's an independent risk factor for cardiovascular disease. And some of the glucose-lowering agents, despite having similar effects on hemoglobin A1c, they have a greater risk for hypoglycemia. And we believe that those medications should be avoided, or at least consider last-line therapy, such as, for instance, sulfonylurea, which is definitely efficacious from a glucose-lowering standpoint, but has a very high risk for hypoglycemia. And especially in the most fragile population, and for instance, in older adults, those should clearly be avoided. It is important to remember that cardiovascular disease is one of the leading cause of death worldwide, and particularly in patients with type 2 diabetes. So being able to reduce cardiovascular risk in these patients is a great achievement, and we weren't able to do it until just 4 or 5 years ago, when these new clinical trials have actually been published, suggesting that some medications can not only be safe from a cardiovascular standpoint compared to placebo, but it can actually be superior and be beneficial from a cardiovascular disease standpoint. There is a potential beneficial effect also for patients without type 2 diabetes. And the reason I'm saying that is that in many of these clinical trials showing reduction in cardiovascular events, the reduction in hemoglobin A1C, which is a measure of glycemic control over time, was very minimal. In some of the studies, the reduction was about 0.3%, like think about the EMPEREG outcome trial. And despite that, there were significant improvement in cardiovascular events, and actually there was a reduction in hospitalization for heart failure within a few weeks from the beginning of the trial, suggesting that some of the effect might be unrelated, or at least in part independent from glycemic control. And in fact, that we know that we have ongoing clinical trials in patients with diabetes and without diabetes with some of this medication. In clinical trials, for instance, one of the biggest limitations of clinical trials, and this has been a limitation not just for type 2 diabetes, for any field, cardiology, and pretty much in any field that you could think of. The majority of patients enrolled in clinical trials are white Caucasians. And for instance, here in Richmond, Virginia, we have a very high prevalence of patients who are African American. And so we definitely need more clinical trials investigating this medication also in this population, because we assume that some of these treatments will work in any patients, including Asians as well, but it might not be necessarily true. We know now very well that some of the medications that have been used, for instance, in heart failure, they seem only to be working in one or the other population, in one or the other ethnicity. And so that's another important field in which we should probably work better, and we have a great opportunity here at VCU in which our population is very diverse, and we can definitely improve the field in that sense. Most of these patients in the clinical trials, they have some degree of overweight or obesity. We know now in the United States about 7 to 8% of the population is actually severely obese, meaning that they have a body mass index greater than 40, which is it's a big concern. And most of these clinical trials do not enroll these patients in their because of their high body mass index. And I hope that in the future we will be able to enroll these patients, because otherwise we will never really be able to find new therapies for this population, which is increasing, unfortunately, like again in the United States, and we definitely need to work and do a better job in finding therapies for this subpopulation as well.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.